go with the symptoms. Okay, so in this axis we'll go for the symptoms, and on this axis we'll go for the exacerbations. So exacerbations means if it more than two or more than one leading to the hospital admission. Okay, so hospital admission. So what is moderate and what is severe exacerbation will come on the exacerbations slides. Okay, so on the coming slides, what is 0 or 1 is not leading the hospital admission. Okay, so 0 or 1 is not leading to any hospital admission exacerbations on that. So if the patient has A means there is no zero not leading to hospital admission, and the patient has a MMRC dyspnea scale of 0 to 1, and CAT assessment is less than 10, then it's A. Okay, so the patient is in the A. And then if it is B, at the time so we'll rejoin again. And B means, so if MMRC is more than 2 or CAT is more than 10, if B, and if it is not leading to a hospital admission is B. While C is there is a less symptoms and there is more exacerbations. Okay, so more exacerbations, this is less symptoms and there is more symptoms. So it is less symptoms is there and then there is more exacerbations is there, it comes under C. While D is more symptoms along with more is a high risk exacerbations is there, so it comes into D. So why this is important? Because for A the treatment protocol is different, for B treatment protocol is different, and for C treatment protocol is different, and for D the treatment protocol is different. So that will come. Okay, so come on the coming slides. So coming to the management, so always you will ask for the smoking cessation. The smoking cessation is the foremost thing that you are always advised to the any patient. So this is the 5 A's that you are using for the smoking cessation. You have to ask the patient whether they are willing to quit or not. Okay, and then you will advise the patient to strongly urge all tobacco users to quit, and then we have to assess whether there is a willingness or not in the patient. Okay, so if you are advising to the patient, if they are not willing, then after going back going out from your OPD chamber, the patient will say that doctor will tell like that, I will not quit. Okay, so that's mainly a thing. So you have to assess whether they have desire or not. Okay, and then you have to assist. So there is a lot of assistance that you can give. So it's mainly a counseling, and then there are certain medical therapies that you can do. Okay, use, and then arrange the follow-up according to that. So this is how you are going to do the smoking cessation. The another thing that for every stages of COPD, the vaccination is advisable. So what are the vaccinations that is always advisable for any COPD? So you are going to give the influenza vaccination every yearly. Okay, so every yearly, and then you have to advise the patient to take the 23 pneumococcal polysaccharide vaccine, PPSB 23, has been shown to reduce the incidence of the community-acquired pneumonia. And also, you are going to give the PCB 13. Okay, so the PCB 13 and PPSB 23 vaccine to the patient with a COPD. And now they have added to give the diphtheria and pertussis vaccination if the patient has not taken this in their adolescent time in the regular vaccination. Okay, so you can give the pertussis and the diphtheria vaccinations for the patient with COPD. So these are the vaccination for stable COPD for every case. And now the another treatment strategies. So as already told in the asthma class, so we'll using the beta 2 agonist. So it can be a short acting like phenytoin, levovitrol, salbutamol is available out here. Okay, and torbutalin, and the long acting like formoterol, indacaterol, salmeterol. Okay, so salmeterol and formoterol is only available out here. So indacaterol is not here. Okay, available here. So it is in India. It is available. So you can use, and you can use the short acting case SAMAs and LAMAs. Okay, so SAMA and LAMAs. So SAMAs are ipratropium bromide. So it's short acting, and the long acting is the glycopyrrolium is available out here, and tiotropium is available out here. Okay, so and glycopyrrolate is also there. So these are the long actings that you are going to use as a LAMAs, and the combination of short acting and beta 2 agonist plus anticholinergics in one device is available. So like salbutamol and ipratropium is there, and then formoterol and glycopyrrolium and indacaterol and glycopyrrolium is also available there. And the methyl like aminophylline and theophylline can be used. And then the combination of long-acting beta-2 agonist plus corticosteroids in one device you can use. Okay, so LABAs with ICS that you can use, and the triple combination in one device like fluticasone, imecladium and vilanterol, beclomethasone, formoterol and glycopyrrolium, butynoside, formoterol and glycopyrrolate. So all these are the triple therapies in the available in the one device, but it is not still not available in the Nepal. And the phosphodiesterase inhibitors, that is roflumilast. Okay, so that can be used, and the mucolytic agents like carbocystine and salcystine can be used for the as a mucolytics. So these are the drugs which can be used. So what are the sorry. So anti-inflammatory therapy in still COPD you can use as the inhaled bronchodilator you have to use, and so inhaled corticosteroids and ICS combined with LABA is more effective than the individual components in improving the lung function and health status, reducing the exacerbations. So it is helpful for reducing the exacerbations. Okay, so regular treatment with ICS increase the risk of pneumonia. So that's another one, especially in those with severe disease. So triple inhaled therapy, LAMA and ICS improves lung function, symptoms and health status, and reduces exacerbation compared to LABA and ICS, okay, as a monotherapy. So recent data suggests a beneficial effect versus fixed dose LABA and LAMA combination on mortality in symptomatic COPD patient with a history of frequent or severe exacerbation. So oral glucocorticoids are only used in case of patient with exacerbation only, and phosphodiesterase inhibitors with chronic bronchitis, severe or very severe COPD with a history of exacerbation you can use. Okay, so on this, and the antibiotics. So long-term azithromycin or erythromycin therapy reduce the exacerbation over 1 year. So in this, the azithromycin is not used as antibiotics; it is used as the immunomodulators. Okay, so immunomodulators you can use, and mucoregulators and the antioxidants can be used like carbocystine, ergocystine, or N-acetylcysteines can be used. So it reduces the risk of exacerbation in selected population that can be used. And then the another is now is the statins. So statins do not prevent exacerbation in COPD patient with increased risk of exacerbation without indication for therapy. However, observation has shown that the statins may have a positive effects on the outcomes of the patient with COPD who we receive them for the cardiovascular and metabolic indications. Okay, so statins is, if there is a high risk of having a cardiovascular or metabolic risk, then we can use the statins on this group of the patient. So, and well as the leukotriene modifiers which are using in the asthma has not been tested adequately in COPD. So there is no any role is questionable of the montelukast and dapagliflozin in case of COPD. So with this background, so what are the factors when initiating the ICS treatment? So strong support of initiating the ICS is the history of hospitalizations for exacerbation you are going to use in the patient. If the patient has a more than 2 moderate exacerbation of COPD per year, you can use. If the patient absolute eosinophil count is more than 300 cells per microliter, so in that case, it's advisable to use the inhaled corticosteroids, and the history of combination of asthma and COPD overlap syndrome, that you can use the treatment of this inhaled corticosteroids. So what is the organs to use? So if there's a repeated pneumonia events, in that case, you can consider for stopping the ICS, and the blood eosinophils is less than 100, and history of mycobacterial infection. So if there is a history of tuberculosis, then we can consider against the use of using the inhaled corticosteroids. So what is the goals for the treatment of stable COPD? So mainly the goals is to relieve the symptoms and improve the exercise tolerance and improve the health status. Okay, so this is mainly that you have to reduce the symptoms, and so you are not going to completely cure the COPD, so you are only going to reduce the symptoms. Okay, so this is the one, and another is to reduce the risk. So prevent the disease progression, prevent and treat the exacerbation, and mainly reduce the mortality. So this is the goal of treatment of stable COPD. So what is the management cycle? So first you have to review the symptoms every time the patient presents to you, the symptoms like dyspnea and whether there is an exacerbation or not, and you have to assess. So first assess always in asthma also, in COPD also. So what are the inhaler techniques? The inhaler techniques is good or not? They are adhering to the inhaler technique, inhaler or not, inhalation treatment or not, and the non-pharmacological approaches like pulmonary rehabilitation and self-management education, and then the smoking cessation, all these are there or not, and then adjust and then escalate your treatment, switch inhaler device or molecules, and according to that you can de-escalate if the patient is being controlled. Okay, so with this, so this is the ideal thing. So what is the follow-up and pharmacological management? So if the response to the initial treatment is appropriate, maintain it. If not, consider predominant treatable trait to target dyspnea or exacerbation. Use exacerbation pathways if both exacerbation and dyspnea need to be targeted. Okay, so and place the patient in a box corresponding with the current treatment, and follow the indications. Okay, and assess response as I told in the previous slide. And these recommendations do not depend on the ABCD assessment at the diagnosis. Okay, so this is not, so you have to follow up with the two symptoms, that is dyspnea and exacerbations. So if the patient